Here today with Becky Mueller, who is part of Meet the PAs podcast, as well as PA Helpers Canada. Thank you for being here, Becky.
Thanks for having me, Anne.
Yes, of course. Can you tell us a little bit about yourself?
Yes, I'm obviously a physician assistant, hence why I'm here. I graduated in the States. I trained in Chicago in 2010, and I have been practicing ever since, mostly in Ontario, actually. And I first practiced in Owen Sound, Ontario, and then I practiced in Brampton, Ontario. In Owen Sound, I focused on active, like curative intent oncology patients, as well as palliative patients. And when I moved to the Brampton clinic, I focused only on palliative patients, the majority of which were cancer patients, but it also encompassed everyone under the palliative umbrella. So also end-stage heart disease and kidney disease and liver disease, etc.
And what exactly is palliative care?
Palliative care is an umbrella term, and it's really a term that comes with a lot of controversy. A number of people in the field wish to change the term because people have a negative connotation with the word palliative. But basically, it means anyone who has a life-ending illness. It doesn't mean it has to be immediately life-ending, but it would be something non-curative. And so then we might talk about more specific genres within palliative care. For example, hospice or end-of-life care would be, in the last 3-ish estimated months of care. But really, palliative care can encompass many people over years.
And what are some of those other genres? Is it just hospice and end-of-life, or are there other aspects of palliative care?
There are definitely other aspects. In fact, most people wish that we would see palliative patients much earlier, because most of the time they're referred to a palliative team really towards the end stages of life, those last 3 to 6 months or last year or so. But many people are actually diagnosed with a life-ending illness or a non-curative illness years before. For example, Alzheimer's disease and dementia, those typically take many years for them to actually end someone's life. Same with heart disease and kidney disease. These things tend to take a number of years. And studies after study after study repeatedly shows that those who are referred to a palliative team earlier on actually live longer with better quality of life. So we really wish that patients were referred sooner rather than waiting till the end and we're kind of playing catch up. If we see them sooner, we're not talking about end-of-life care at that time, but we may be doing lots of emotional support. So if we see patients sooner, we're much more likely to be able to address their symptoms and their concerns. It certainly by no means signifies that we're not doing active treatment. They would continue seeing their cardiologist or their nephrologist or their oncologist and continue whatever active treatment they wish to have. So yeah, we can be provided anywhere, and that team should encompass a physician, either a nurse practitioner or a PA or both, nursing staff, nursing support staff, as well as social work, physiotherapy, occupational therapy. The list is really pretty broad as to who should be on that team to be able to provide the best support.
And how does a PA fall into this role within the palliative care team?
I think I fell in a bit accidentally. So initially, when I got my job in Owen Sound, I didn't know that I had an interest in palliative care. I went there because I did really like oncology and I also needed a job. So those things were right up my alley. And then throughout my time there, I was exposed to palliative patients and really enjoyed my time with them and felt very blessed to be able to have that time with them. So I took a second job in Brampton to really focus only on the palliative side, since I had such a interest in that and a like for that. So it was a bit surprising. And when I took the Brampton job, I actually didn't know that it was going to be fully palliative care. I took that job through a family practice, a private family practice, and the idea was that I would have some palliative patients, but that I'd also have to see regular clinic patients in the family practice. And then after a couple months, through discussions with the physician, it really became clear that there were plenty of palliative patients that really needed my time and that I had a definite skill in that area. So I actually didn't see the regular family clinic patients at all.
And what are some of your clinical responsibilities that go along with being a palliative care PA?
So obviously you have to deal with the paperwork side. So everybody's always going to talk about a DNR status, which, by the way, is not required to be receiving palliative care. DNR is 100% optional based off of what the patient's wishes are. So they do not require a DNR to be under palliative care service. They do, however, they would require that in order to be seen in a residential hospice setting. But otherwise, they could be anywhere else they wish to be with a full code if that was their true desire. But you would take care of any of that paperwork. If you don't have a social worker on your team, you would also help take care of any other general medical directive paperwork, so what their end of life wishes would be. And I like to get a little bit more detailed with this than just the general paperwork forms, because you want to talk not just about life support in the DNR status, but also about, do you want antibiotics? Those are potentially life-saving, right? But they don't necessarily help with help prolong your life in the grand scheme of things. They might prolong it for a few days or a few weeks. And they certainly don't really help with symptom management when you're in the last stages of life. So that's always up for discussion. We also talk about fluids, IV fluids, and if that's something they want or not. And we try to also have a discussion about what the nutritional status may be for that patient, particularly if they have something that would be bringing up questions of that, like someone who with a GI cancer or a gastric cancer of some kind, pancreatic cancer. Those patients often have nutritional status issues that can make the family especially very concerned. But so we want to have those discussions. You would take care of any admission paperwork, either to the hospital or to the hospice, residential hospice, or long-term care facility that would accompany that. So there's the paperwork side, but then there's also the taking care of the patient side. So you need to visit them regularly, and you take care of their visits either on a month by month or depending on how they're doing, right? So sometimes I would even be seeing patients daily when they're in those last stages, and do their full physical exam, all of the symptom management. If need be, you would be responsible for blood draws and other things like that. I really didn't have to do procedures, but some people would. One of the procedures that I never learned how to do, but most certainly would be useful, would be bedside paracentesis. If you can have the skill level to be able to do that, so the patients don't actually have to go into a facility to have a paracentesis done, it's very useful in the palliative setting.
Excellent. And how does this role look different from what a what a physician would do, or what a nurse practitioner would do?
Well, my opinion on the nurse practitioner route is that our roles are very, very similar, and that patients and families rarely can tell the difference. So in terms of a clinic side and how patients perceive us, NPs and PAs really are not going to be perceived any differently. As far as a technical side, the difference between PA and NP would be prescribing authority. Obviously, the palliative care population does require a lot of narcotics. Pain control is a main concern for patients in end of life, so that is obviously something that PAs cannot prescribe at this time. And certainly physicians would be the main providers prescribing that, but nurse practitioners also have some ability to prescribe narcotics. So that would be like a technical difference between us. However, I have to say that I really didn't feel that was a hindrance for me providing my work duties. I was certainly able to call my supervising physician or text him and say, I just saw so-and-so, their pain is rated here on this scale, here's where the issues are. I think we should go to this level on the short acting and the long acting pain control, or whatever that might be, or we should augment it with a secondary form of pain control. And usually the relationship between me and the primary care physician was good enough that that wasn't really an issue, and he'd write the script.
Excellent. And what should a patient expect when interacting with a PA?
The patient should expect somebody who's very empathetic and a very good listener. I think if you look at the day-to-day physical exam things, those aren't really going to be different from any other PA and a PA, PA in palliative care. But one of the key differences would be someone who can sit down, really empathize and listen, because that's a really key tool to be able to listen to the patient, listen to the family members. A lot of times what they need is just someone to sit down with them for an hour, hear their concerns, and either validate those concerns and explain how we can alleviate them, or say why they shouldn't be a main concern for whatever reason, and explain the methodology behind that. But I really think that being able to sit down and listen to somebody is a key difference that you're going to find between a PA in any other practice and in palliative care.
And how do you interact with patients' families in palliative care?
The same way you would in many other settings. Obviously, the family is very involved in palliative care settings typically. And if they're not involved, it's actually a little bit sad. But typically they're very involved. And just like in a pediatric population where the families are very involved and they have to be taken into consideration, the same goes true in the palliative setting. There's often family meetings that are scheduled, and we do those in advance so that family members who are working or out of town, are able to come to those meetings and have all of their questions and concerns addressed. Patients are generally very concerned about how their family members are managing and handling the diagnosis, often more so than, how they're doing themselves. So we have to be sure that we address that. Within that, though, we also have to be sure that we're still respecting the patient's privacy, autonomy, and wishes of what they want shared or not shared.
And you had mentioned a couple of terminal illnesses or diagnoses, like Alzheimer's, cancer. What are some other conditions that would come through in palliative care?
The ones that I saw most commonly would be any advanced cancer diagnosis. Dementia was also extremely common, and it's so hard because it does take a number of years for that to actually end somebody's life, which can be a challenge in and of itself. I mean, no family member wants to say, I wish this person's life was shorter, and no patient really wishes to say that. But at the same time, living with that continual deterioration is very difficult. So we need to make sure we have extra supports in place to help manage that. I mean, even just managing somebody who's bedbound for 10 years can be really challenging. And it's also very difficult to estimate when a dementia patient is near the last weeks to months of life, because that illness does have this very slow course, and they often get worse, and then they just stay in that spot and don't continue to deteriorate for a while later. So that in and of itself is very challenging. But dementia patients are very commonly seen, as is end-stage heart disease, end-stage liver disease, end-stage kidney disease. And of course, kidney and liver go together. So by the time you're seeing one for end-stage liver, they usually also have end-stage kidney at the same time. Other things that could happen in there, ALS, these things are not as common, and I never encountered the neurologic diagnoses that would end someone's life. I never saw patients like that, and I never saw very, very young patients either. So, but those would be more unique things that certainly would qualify.
And what were some of the positives or benefits of working as a PA in palliative care?
Oh, I think it's one of the best areas to work. First of all, you have some of the most rewarding patients. Not only do you feel like you're actually making a difference on a day-to-day basis, because you're really impacting that patient's quality of life, but they're also very grateful, as are the family members. I felt so welcomed into people's private homes and very vulnerable private moments of life. And I really, whenever I worked in covering a family practice or an urgent, care, you don't get that same kind of reward. Oftentimes people are even walking away angry from you because you're not giving them the pain pills or the antibiotics that they came in wanting. In this palliative setting, everybody is grateful, despite the very difficult time that they're going through and the many emotions that they're experiencing. Everybody is really quite grateful. So it's a very rewarding practice. I would also say that it is emotionally trying. So you have to be a person who is able to manage those emotions. it's not that you don't want to feel the emotions, because that's just not being human. And I think we all feel sad, and it's okay to feel sad, but you have to be able to not have that take over your life. So being able to manage those emotions, I do feel, is a skill. I don't think it's a skill that you're necessarily born with, and a lot of people can learn that, but it is something to be cognizant of, and it can be a bit draining. So you want to have a way to, go home at the end of the day and replenish yourself and be able to come back the next day fully charged for that. And I don't think it's one that really goes away. I think it's one you have to continually check on yourself with. You have to continually monitor. There are now actually programs designed to help any caregiver, not just PAs and physicians, but any clinician in a palliative setting, to help them deal with emotions and manage death and continue on with life. Death is a part of life that we all are going to experience. It's inevitable, and it's part of the normal cycle, but we go into a healthcare field initially with the goal of fixing people. So when you can't fix the original problem, that can be a challenge. But we do have to look at death a little bit differently. There can always be hope, not necessarily hope of the cure, but there can be hope of reconciling differences within family members, hope of reconciling faith. You see that a lot. People who spent years away from faith, in those last moments may come to it, and they can reconcile these kind of unsolved emotional issues that they may have been having for many years of their life, not just the patient, but also the family members involved. So you can find hope in anything. You can hope to not have pain, hope to die peacefully, hope to die calmly in your sleep. There's so many parts of hope that can still be established and supported in the palliative setting, not just this hope for a cure, which is the only one we think about. And so anyway, there's a lot of support programs that are now in place for clinicians and people who practice in the palliative care setting. You do have to continually check in with yourself, and some patients are going to affect you more and more intensely than others.
And just sort of to rewind a little bit, can you describe what a typical day would look like for a PA in palliative care, or at least in your experience?
Yeah, so I would travel. Most of my patients I was not seeing in clinic because most of them were too ill for that. So I would travel from around to patients' homes as well as to the residential hospice. I did not travel to the hospital because the hospital in Brampton, unfortunately, did not allow me authority in the hospital. So that was a different battle. That's a different battle. But so I didn't go to the hospital. My physician did that. I would see roughly 10 patients in a day, and I'd leave 1 or 2 spots open for an emergency urgent visit. And it sounds like not that many patients, which is true. Number one, I would like to have as much time allotted for that patient as they need. And sometimes it's quick visit, and sometimes it's an hour and a half. And I did my very best to make sure that patients felt that they received the full capacity of the care they needed that day, which sometimes does include, like I said before, just listening. And that can take a while. And then there's also travel between homes and between sites. So you need to accommodate for that travel time as well. So I would see roughly 10 patients a day. I'd do my very best I schedule them myself. I actually did not use the front desk staff to do any kind of scheduling for me because it ended up being too complicated. I needed to schedule them based on urgency as well as based on their physical location, because I didn't want to have to be backtracking in my travels throughout the day. I would rather have them go progressively in one direction.
Right.
So and have it make sense. So I scheduled everything myself, and I would schedule one generally like the closest to my house, and then or the closest to the clinic, and then move out through the day as I could. And I did the best with that I could. I would typically allot for an hour per patient.
Mm-hmm.
Yeah, and it's you assess them, you chat with them, you see how they're doing, you make sure you're always assessing, a pain scale, you're always assessing the performance status and nutritional status. You want to make sure you're always addressing bowel habits as well, so that that's not causing a comfort issue, and any other particular issues that they may, symptoms that they are particularly experiencing. You want to make sure you check for bed sores and all that kind of stuff too, as they're often pretty non-mobile.
Mm-hmm.
And then I would do an exam and order any blood work if need be. However, I'm very conservative on blood work. If we don't need to be ordering blood work, I'm not going to order the blood work. You know, if it's not going to change our overall position here, there's no reason I need to check on somebody's creatinine level who's in end stage renal failure, because I know what the answer is going to be. It's not going to be good, and I'm not going to change any of my practice or any treatment based off of that. So I wouldn't just order routine, you know, kidney level, kidney functions on patients who are in kidney failure. That doesn't make sense to me unless they're on dialysis, right?
Right.
Yeah, same with electrolytes. I wouldn't you know, I would stay away from the electrolytes unless we knew that that's something that we would treat. So I'm pretty conservative on what I would order blood work wise. What I would not be so conservative on would be keeping them, anything that would keep them comfortable. So if a paracentesis is going to keep them comfortable, I'd make sure we get that ordered and make sure we get that patient scheduled. So I'd be making whatever phone calls I need to be making to get that scheduled. If they needed more frequent visits from CCAC or whatever home care they were using, I'd make sure I have close contact with the nursing facility that was coming in and doing their visits, etc.
And what difference does it make for patients when they're receiving the care at home from a provider like yourself versus being in the hospital?
Well, there are so many things that make a difference. Okay, that's okay. Patients have routinely been surveyed again and again and again in both in Ontario as well as throughout Canada, and consistently the vast majority of people wish to spend their last days at home. So in and of that alone, this is better. It's where they want to be. So patients deserve to be treated at home because that's where they want to be. They're more likely to be comfortable there, and they're already not comfortable, right? They already have a life-altering, life-ending illness, and they already have the symptoms that go along with that. So we should alleviate everything we can. And one of them is location. We can absolutely help patients die at home. In fact, everybody is allowed the right to that in Canada, but not everybody knows they have the right to that. And of course, the logistics within that become a little more complicated. For example, funding for CCAC and home care throughout the provinces and even within different districts of the provinces are different. So some areas, patients might be able to receive a visiting nurse several times a day for helping changing their diapers or changing their position, giving medications, whatever that might be. Whereas in other areas, there might only be funding for a visit once or twice a week. And so then you have to have family around that can supplement that, or the finances to supplement that. So everybody has the right to die at home, but not everybody has the logistical capacity to make that happen. It does happen more frequently when you have a palliative team on board, because we know the resources, we can connect patients and their family members to that, and we can really help support them. And obviously we do home visits, so that helps. So we need patients to be passing away at home if that's where they want to be. The other thing is hospitals are not where patients should be going to die. Hospitals are where patients go to get better and get acute treatment for whatever that issue may be. And so the idea is you get in and you get out. And this is not for any specific area of medicine. This is across the board. Whether you're having a baby or you have pneumonia or sepsis, you are supposed to get in for the acute issue and then get out. Hospitals are more likely to cause infection. They're very loud, and this is not really an avoidable issue. They're very loud, and patients in the end of life need peace and quiet. We've researched this, and we've looked at brainwaves even when patients aren't able to verbally communicate, and they respond better when we have calm, quiet environments. So the hospital is not going to be able, and under no circumstances is a hospital able to really provide that. You know, buzzers are constantly going off, things are going on the overhead, things are beeping. It's also more likely that patients are going to have interventions if they're in the hospital. So blood work, even blood work, if you think about it, and we think that it's not a big deal, but if you think about being in your last days of life when all you want is peace and quiet, and you need things to be calm in order for your soul to be calm in this process, and your system is acutely more sensitive to its surroundings than it may otherwise be, and you have someone bugging you at 5 o'clock in the morning to draw your blood or whatever that may be, it's really not conducive to a comfortable last few days. There are hospitals that do have hospice settings because there are areas that don't have residential hospices, and so then what they do is they often convert an area of the hospital or one room of the hospital for this service, and it is sometimes needed and unavoidable, especially in those who were unable to treat the symptoms at home for whatever reason that might be. And it's unavoidable, and they do their very best to make this as comfortable as possible. The rooms are typically smaller. There's not always enough space for family. It's just not the best for all of these reasons, but it is sometimes necessary.
And can you clarify what hospice means or what that is?
So hospice, there's two definitions here. Hospice in general would mean your last few weeks to months of life, receiving care during that time. A residential hospice, however, is a physical facility that you would go to during that time of life. And they're really nice facilities, actually. If it's not possible for people to pass away at home, it is a covered thing, completely paid for by the government. And so you get a very large room. Usually these rooms have a pull-out couch so family members can sleep on them, very large bathrooms. They usually have some type of garden area to help facilitate, this peaceful, quiet, beautiful, serene space to be in during this time. They usually have a kids room or area so that kids who need to play have a space to be. They often have food for family members, not just for the patients. And patients often aren't eating at that time of life anyway, but family members certainly are. And so they often and usually do have a volunteer staff to cook food for patients' families and make sure they're comfortable. There's often showers and other types of facilities, so family members who are there for a long time have a place to clean up and be comfortable themselves. They're really, really nice and very accommodating. The trouble with them is that the bed space is limited. Because rooms are so large, they can't accommodate the numbers that per se a hospital can. For example, the hospice in Brampton that I worked at had 10 beds. So there's not a lot of space there for the number of patients who maybe want to get in. And so then you would be put on a waiting list, and maybe there's time for you to wait for a space to open and maybe there's not. But they're really beautiful places, and I've not had a single complaint from anybody coming from them. I would say the only hard thing that I ran into, other than bed availability, was language barriers and cultural barriers. So they did their very best to accommodate all those things, but they couldn't guarantee that a nurse would be on staff at that moment, overnight or whatever time of day, that spoke the same language as the patient. So that was the only issue, and it certainly wasn't something that the hospice was unaware of. That was something they were very aware of and were trying to find ways to overcome, because it is something that is important to deal with, obviously.
And what difference do you find the palliative care service notices with having a PA on the team, or at least working with you?
Well, it helped provide 24-hour on-call care. So I split between my supervising physician and I, we split the call. So 50% of the time I was on call and 50% of the time he was on call. Obviously, anytime I'm on call, he has to be on backup call. But the reality is that PAs are very capable of managing the vast majority of issues that come through, especially if you plan well. So if I think maybe once there was a time where I was on call that I had to call him as well, but that was it. So we were able to provide a 24-hour service to our patients, palliative patients, which is a big deal. And really, if you're going to provide good quality palliative care, you need to have 24-hour access. And we were also able to visit patients more regularly. They had very quick access. If they called that day for an issue, they received care that same day, and we resolved whatever issue they were having the same day. And that was not happening prior to me being there. So I think that was the biggest thing, is the amount of access that they received is the biggest difference that patients had. But the other thing, obviously, is that a lot of family physicians are not really doing a palliative care service. The fact that I was there, I created the palliative care service while I was there. That was 100% created by me, supported by my supervising physician, but it didn't exist before me. There are not enough palliative care teams in the GTA. So in fact, there's a study that came out, I guess it was about 6 months ago, citing the number of patients that should receive palliative care, wanted palliative care, but did not receive it before they died. And it was a fairly high number. And I don't know if I want to say a number because I'm going to remember it wrong, but I think it was about 40% of patients who asked for palliative care did not receive palliative care before they died.
Mm-hmm. And it seems like PAs are an untapped resource in terms of helping family physicians expand their role in providing palliative care access. Do you see this as an area for growth for PAs potentially?
Obviously, yeah. I think it's an area that doesn't receive a lot of focus in many of our conventions and discussions in school, et cetera, but it's an area that really needs it. The same with nurse practitioners. I think nurse practitioners are more commonly found in palliative care than PAs, but they've just been around longer. So I don't think there's really a reason why they have to be more in that market than we do. I think, in fact, it might even be the other way around, because physicians in palliative care often want to have a relationship with the patients, even though they don't have the time to be there with every single patient in the same manner. And because PAs are a little bit more physician extenders rather than NPs being a bit more independent, we tend to have a more close relationship. However, I'll say that with the caveat that I really think NPs and PAs can function equally successfully in this role, and that both of our professions should be more involved in palliative care and providing this service. If there's ever a time in life that you deserved the best care, it is during your end of days. Everybody deserves to die peacefully, quietly, and without pain. And right now in Canada, that is not happening. I will say, though, that Canada is one of the forerunners. We are a leader in palliative care in the world on the global setting, but we're not there. We still have a long ways to go.
Of course. And if a physician or suppose a LHIN, local health integration network, were interested in incorporating a PA onto a palliative service, what are some first steps or things they should look into before adding a PA to their service?
I mean, I'm not sure I know how to answer that question exactly. I wish I knew more about how LHINs, like the logistics of how LHINs need to hire PAs, but they're already hiring PAs. So it's not like this insurmountable task. I mean, the real thing is recognizing that palliative care needs PAs working in that area, and then they need to devote money towards it. And you go about hiring them just as you would in any other practice. The key would be to find the person who's the right fit for that role, because I do think you have to, the medical piece of palliative care is not that complicated. There are a few common things that you see again and again and again and again, and anybody can learn that. The hard piece, which I alluded to earlier, is the emotional piece that comes along with palliative care. So you just have to find the right fit in terms of the PA to hire for that. But otherwise, I think you would hire them in any other fashion that you would. The first step is actually recognizing that it's a need. And I don't think very many other private physician practices, LHINs, I don't think many of them actually recognize that this is a need or a service that PAs can fulfill. So that, I think, actually falls to us to be networking and advocating for our profession.
Absolutely.
And these patients.
And I just wanted to sort of round out our discussion with a few tips maybe you can give for students or PAs that are interested in palliative care. You touched on it a little bit earlier on, but what characteristics would you say one should have or be prepared to work on and develop if they're thinking about transitioning into a role in palliative care?
Yeah, the first thing is learning the medical piece, the medicine of it, right? Which is,
Right.
like I said, not that hard. You can learn that. You can learn it on the job. Everybody who graduated from a PA program and passed the exam is very capable of learning the medicine involved in palliative care and how to manage those symptoms. What the harder piece to do is to work on listening skills, and it's something I still have to work on myself. It's something I constantly am working on, and I'm always checking in with myself on the emotional side of things as well. And so I think anybody going into this role has to go in with the understanding that that's the piece that they will have to work on. Even if they're really good at it right now, at some point they're going to find they need to check in with themselves and figure out how to manage it, whether that's going to be taking some time off, whether that would be making sure they involve themselves in their hobbies, or meditating. Walking meditation or just self-awareness works really well for me, and so that's how I use it. I'm also use my faith, and so if you're not a faith-based person, you can still work in palliative care, but you do have to have a way of mitigating your spiritual self as well as your emotional self throughout that process, which anybody can do. You just have to be aware of it going in. And also be aware of the lack of understanding in other professions and colleagues, and how can we stay calm throughout that process and not take that to heart, take that home as being your fault. I have really struggled with that, but many people are very capable of overcoming that and moving forward. And I think the palliative care clinicians as a whole are making progress. I do think that most Canadian clinicians are at least aware of the basis of what that is and do acknowledge the autonomy that should come along with that. And being that we've had so much news coverage of MAID happening, I think more people are more aware of that. MAID was legal. I think it was 2016 that MAID was legalized, and PAs are not allowed to carry that out. Nurse practitioners can, and so can physicians. Most practitioners do support MAID and choosing to die on your own terms, but there's a lot of
sorry, can you say what MAID stands for just for our audience?
medical assistance in death.
Okay, thank you.
Assistance in death. Sorry, yeah. And that so it's legal across Canada, but there's still a lot of complexities happening with that and things that need to be worked out. But I do think that the fact that that is so covered in news stories across the country has made clinicians on the whole more aware and at least thinking about that a little bit more.
And yeah, I think that's all of my questions. So was there anything else you wanted to touch on, or any other areas that you'd like to talk about?
I hope that people find this interview very helpful. I hope some people consider going into palliative practice. And even if you don't do 100% palliative care, everybody has patients who are palliative in their practice. You know, most people run into, there are a few that don't. Like if you're doing an orthopedic practice, you're probably not seeing those patients long term. But most people in family practice or in a general practice, internal medicine, oncology, and neurology, cardiology, all of these practices have patients who are palliative in them. So you can incorporate ideas of palliative care and practice into your practice daily, even if that's not what you dedicate most of your time to. And the biggest thing would just be listening to patients, making them aware of their choices, and supporting those choices.
So if there was anyone that was interested in learning more about like palliative care, the tenets of palliative care, how it's done in Canada, where's a good place to start to look?
Physicians in Palliative Care group,
Okay.
and they're a national Canadian group. They're led by partially family physicians, and the other half of them are specialized palliative care physicians, and they do research throughout Canada on palliative care, and they also have a goal of connecting with government and more awareness, both public as well as within the public sector with patients, as well as within the hospital and clinic setting. So that's a really good place to connect, and you can see the research and recommendations that are happening. They put out guidelines as well. And then, of course, you can always, I'm always happy to answer questions if people want to contact me.
And they can reach you through LinkedIn or rlmwriting@gmail.com?
That's correct. Yeah.
Okay, I think I've memorized that by now. So,
Yeah. That was really
so
good.
Becky, thank you so much for your time, and I really appreciate it. So I'll put everything in the show notes so everybody can find ways to get in contact with you.
Thank you so much, Anne. Thanks for having me
Great.
on.